Myself, Dr. Suresh Kumar Jayakishan Bishnoi, working as an assistant professor in the Department of Cardiology at UNMICRC Institute of Cardiology. Today we will be discussing the pulse in clinical examination. The pulse, JVP, blood pressure, apex, S2, these are some hard clinical findings which should be always examined in the great detail to arrive a diagnosis in any clinical case. And this topic is a must read for all the postgraduates from top to bottom to perform a great in examinations. So definition of pulse is basically it's an expansion and elongation of the arterial wall due to pressure which is imparted by the column of the blood during cardiac cycle. So the pulse is basically due to elongation of a wave during along the arterial wall, not due to the blood which is ejected during systole. And the arterial pulse waveform is related to many physiological factors, which includes factors starting from the heart and extending up to the periphery. Foremost starting factor is the left ventricular stroke volume. Next is the ejection velocity. Then is followed by the relative compliance of the arterial system and the capacity of the arterial system. This all factor contributes to the contour and the configuration of pulse. This is the typical pulse, central pulse, which was depicted by Dr. Abrams in 1982 and is also taken from there. This is a normal arterial pulse. Initially there is a rapid upstroke which is a rounded summit or peak and the fall in the late systole. And whatever we feel during the pulse examination is only systolic peak that is palpable and diastolic events are not palpable. The pulse has a anacrotic notch which is in during systole, dicrotic notch which marks the end of the systole and beginning of the diastole, and this dicrotic notch coincides with the S2 clinically. And there is a percussion wave which is first part of the systole and there is a tidal wave. So this is a typical diagram of a central pulse which should be learned by every postgraduates to draw and to draw multiple times because it's asked because the students are asked to draw this pulse during exams. As discussed, the first portion of the central aortic pulse reflects the peak velocity of the blood which is ejected during early systole, and that blood is stored in the central aorta. And the mid to late systole portion of the normal pulse wave after anacrotic notch is produced by blood moving from the central aorta to the periphery and simultaneously reflected portion of the pulse which return from the upper part of the body. So these combinedly form the systolic portion of the pulse. The arterial pulse is normally transmitted at a velocity which is almost 10 times greater than the blood flow. And anacrotic and dicrotic notches are normally cannot be felt clinically, but these are recorded during invasive blood pressure or pulse monitoring. And you should not expect clinically to palpate them while examining the arterial pulse. The positive waveforms from the dicrotic notch most likely represent the reflection of the pressure wave from the arteries in the lower half of the body. So the diastolic events after the dicrotic notch are the events which are reflected from the lower half of the body. How does the pulse alters in the periphery? There is whenever there is invasive pulse recording from the central, upper limb, lower limb, or as we go for periphery, there is an alteration in the configuration of the pulse which is depicted by this diagram. And this should also be learned to draw. As we move from the carotid to brachial, radial and femoral, there is a progressive increase in the volume of the pulse and there is a progressive decrease in the height of the dicrotic notch. And this is explained by this. A normal pulse contour is altered with the increasing distance from the aortic wall. The reflecting transmitted waves in the peripheral arteries reverberate and this results in greater amplitude or the height and the velocity of the arterial pulse wave, and there is a lower dicrotic notch. And these changes become progressively more as we move distally. So the lower limbs have a higher systolic blood pressure as compared to the central blood pressure, which commonly we also say as the peripheral augmentation of the blood pressure. So how does the peripheral vascular resistance affects the blood pressure? Instead of whenever there is an increased vascular resistance or stiffness which occurs in a patients with a long-standing hypertension or in a state of vasoconstriction or relatively non-compliant arterial tree contributes to the increasing pulse velocity. and this increase results in the pulse contour with a rapid upstroke, and there is a greater amplitude. Such the patients which are very old, and some of the time when you appreciate that the pulse is a very good volume, but this is some less reliable, because in patients with increased age, even in the low volume pulse, we feel a volume is very good. And this also occurs in the patients with long-standing hypertension, or there is a diffuse vascular disease or arteriosclerosis. So in these subjects of the patients with hypertension, arteriosclerosis, old age, examination of the pulse for the volume is less reliable, because there is a false sense that there is an increased volume or there is a low volume. And the opposite happens when there is intense vasoconstriction. Examples in the patients with high inotropic support. In such a patients, even if the pulse is good or there is a good systemic blood pressure, the palpable pulse may be very reduced, and you get the sense that the pulse is feeble or the blood pressure is low, but that is not true. So these two conditions with extreme vasoconstriction on high inotropic supports, old age, chronic hypertensive, arteriosclerosis, the examination of pulse may not give the correct interpretation. In clinical scenario, whenever you examine a pulse, the following points should be at least documented and remembered. First of all, the rate, then there is a rhythm, pulse volume, pulse contour with a special attention to the crest or peak. Speed or rate of rise of ejection is also very important at the postgraduate level or DM level. You should always comment on what is the rate of rise of the pulse. Then the condition of arterial wall, stiff, dispensable, palpable or non-palpable. You should examine for the equality of pulse on both the sides. Is there any radioradial delay or radiofemoral delay? And other peripheral pulses should be palpable, which may give more clinical information. This is typically how a radial pulse is palpated. You should use the 3-finger method as described in the literature or described previously. Place the pads of 3 middle fingers over the right radial artery and feel the pulse with the base of your fingers. And you should also examine both the radial pulses simultaneously. Normal the pulse rate is between the 60 to 100 per minute. In case of sinus bradycardia, you may have pulse less than 60. In case of sinus tachycardia, pulse is more than 100. Next is examination of a rhythm. So broadly, either we say a patient is having regular pulse or irregular. Then irregular again divided into regularly irregular or irregularly irregular. You should be remembered at least couple of causes for both of these. And these are the common causes for regularly irregular rhythm. The 4 most common in young patients is sinus arrhythmia, then the secondary AV block, then atrial tachyarrhythmias like multifocal atrial tachycardia and atrial flutter whenever associated with the fixed AV block. Or in case of ventricular bigeminy or trigeminy, you also get the regularly irregular rhythm. In case of bigeminy, alternate pulse. In case of trigeminy, after every 2 pulse, you get the regularly irregular rhythm. Whenever you note the irregular rhythm, you should have a couple of things in the back of the mind, like atrial fibrillation, atrial ventricular ectopics which are irregular or coming at a very different intervals, or atrial tachyarrhythmias like multifocal atrial tachycardia and atrial flutter with varying AV blocks. Same, if these atrial tachyarrhythmias have a fixed AV block, they may sense like a regularly irregular rhythm. Sometime clinically in very long standing AF, you might have a regularly irregular rhythm. Then what are the abnormal variants of the pulse? So one of the most found pulse in the clinical examination is hyperkinetic pulse. So what do you mean by hyperkinetic pulse? There is an increase in the volume of the pulse, or we say is a large volume pulse. So hyperkinetic arterial pulse is larger than the normal amplitude, and it results from the increase in left ventricular ejection, velocity, stroke volume or arterial blood pressure. Any of the factor can contribute to the hyperkinetic pulse. And some of the clinically common causes you should remember, like high output states or whenever there is enhanced sympathetic activity. Causes includes anxiety, anemia, thyrotoxicosis after exercise, ventricular septal defects after alcohol intake, aortic regurgitations, patients with the patent ductus arteriosus or large AV fistulas, Paget's disease, severe cirrhosis or cigarette smoking. These all clinical conditions might have a hyperkinetic pulse with an increased pulse volume. So whenever you get a clinically like a hyperkinetic kinetic pulse or increased volume pulse, you should think about all these causes. Keep your diagnosis broad. Should not focus only on the cardiac diagnosis. Should also look at the systemic causes like anemia, anxiety, thyrotoxicosis to exclude other causes. Next, a common type of the hyperkinetic pulse is a collapsing pulse, also known as the water hammer pulse or Corrigan's pulse. So in this pulse, there is a very rapid upstroke. So the initial portion of the pulse, which during systole is a very rapid upstroke, leading to very high systolic blood pressure, and this is basically contributed by increased stroke volume. Then there is a rapid downstroke during the systole, and there is a low diastolic blood pressure. So why does this occur? So there are a couple of theories about it. First of all, it occurs due to very decrease in the peripheral vascular resistance. During initial very rapid ejection, there is a stimulation of the carotid receptors, which reflexly leads to the decreased peripheral vascular resistance, and there is a peripheral runoff of the blood. So there is a rapid decrease and leading to lower diastolic blood pressure. Some people say there is a diastolic runoff of the blood to the LV, but this portion contributes very low. Most of the contribution is by the peripheral runoff of the blood due to reflex, which is initiated by the stimulation of the receptors in the carotid arteries. And common causes are like AR, PDA, RSOV or AV fistulas. So how do we examine the water hammer pulse or Corrigan's pulse? You should palpate when the patient is lying in horizontal position over the radial artery with the palm, and you rapidly uplift the arm by the other hand, which is holding at the brachial artery, and you feel by the palm of the hand which is at the radial artery, and you note the prominent pulsations. Next is and this method is very well asked in examinations to just show how to palpate the water hammer pulse or how to demonstrate the Corrigan's pulse. And this should be done by the students during the clinical classes. Next is the hypokinetic pulse. This is basically small diminished pulse are common in states of low cardiac output. There is a very low stroke volume which contributes to low amplitude of the pulse, and there is a decrease in left ventricular stroke volume which results in shorter left ventricular ejection time as there is a less blood to eject. While assessing, it is important to assess the rate of rise of the hypokinetic pulse. We should examine whether the rise is normal, whether the rise is slow or delayed. It gives the clinical diagnosis about the underlying conditions. So like a normal upstroke, which is unsustained, indicates a decreased stroke volume without any LVAT obstruction in cases of LV dysfunction or hypovolemia. But whenever you have an LVAT obstruction, the low volume pulse has a slow rise, which is a very important to pick because the peak of the pulse is in the late systole, and that indicates that there is some LVAT obstruction like aortic stenosis. Whenever a pulse in hypertrophic cardiomyopathy is a normal volume, but it's a very quick rising. You can say the pulse in the hypertrophic cardiomyopathy is one of the fastest rising pulse in the hypertrophic cardiomyopathy. Then what are the double beating or twice beating pulses? These are basically 2 or 3 types of the double beating pulse you should remember, like a bispherians pulse, when both the peaks are during the systole, and the common causes are aortic regurgitation or the combined lesion with prominent aortic regurgitation and mild to moderate aortic stenosis. When there is a compensated tight aortic stenosis, it's uncommon, but it's mentioned by the Abraham. And how output states. Other type of the double beating pulse is the bifid pulse, also known as a spike and dome, typically seen in hypertrophic cardiomyopathy or say the hypertrophic obstructive cardiomyopathy. And then there is a dichrotic pulse, which is seen in a cardiomyopathy, very severe LV dysfunctions, in tamponades, or young patients with febrile states or septic shock. Dichrotic pulse, and this dichrotic pulse is one peak is during systole and other is during the diastole. We will go into detail of this all pulses one by one and learn how they are produced and what are the mechanisms behind it. So the bispherians pulse, which is shown in the diagram, this is rapid upstroke, then there is a fall, and there is a second upstroke, and this both the upstroke occurs during systole. These are followed by dichrotic notch and rapid decrease. So there is a high systolic blood pressure, low diastolic blood pressure. And this typically occurs in AR or AR with a mild to moderate AS. And where to examine this pulse? Commonly we look to the brachial or radial artery than the carotid artery, because these bisvariance pulses are very well appreciated in the brachial artery as compared to the carotid artery. It may be easily missed when a strong palpating pressure is used. Whenever you are examining a pulse, if you are giving a pressure which is a very tight, or you give a very strong palpating fingers, then you can miss this bisvariance pulse. So to examine this bisvariance pulse, you should light, but there should be a firm compression of the wall with a single finger or thumb, and you should slowly decrease the pressure on your fingers till the character of the underlying pulse comes out. So there should be gentle or light compression to demonstrate this type of the pulse. Why does this occur? The first part occurs due to the rapid ejection of the blood from the LV to the aorta. During the peak flow, Bernoulli's effect on the walls of the ascending aorta causes a sudden decrease in the lateral pressure on the inner aspect of the wall, which causes this fall, which is shown as a notch during the systole. And later at the end of the systole, again there is a strong reflected waves which causes the second peak during the systole. So there is a first peak due to rapid ejection of the blood, then there is a notch or decrease due to Bernoulli's effect, and then the second peak is a strong reflected waves. This is followed by dicrotic notch and the diastole. So we get a very high pulse pressure, and this mechanism should be remembered by everyone. Then next is the bifid pulse or spiconum pulse, typically shown in a hypertrophic obstructive cardiomyopathy, and you should have a mind memory of these two pulse configuration of this spike-endome and this bisvariance pulse. And it is commonly recorded during the invasive blood pressure monitoring or the pulse examination. It's very difficult to demonstrate clinically this bifid pulse, and mechanism is somewhat different as compared to the pulse of a bisvariance. The early systolic emptying of the LV in HOCM is very rapid because the muscles and the LV are very rapidly contracting, and it's a hypercontractile which results in very brisk, we can say one of the rapidest rising pulse in the clinical examination, which causes a tapping arterial pulse wave. And there is at the peak of the systole, there is LVT obstruction, and this LVT obstruction, there is a decrease in flow across the wall or LVOT, which causes the pulse to collapse, and this is again followed by the late systolic pulse. And this dip during the systole, it clearly correlates with the significant outflow obstruction. So whenever during invasive blood pressure monitoring or invasive pulse monitoring, you get this configuration, and this whatever the dip during systole, it significantly correlates with the degree of the LVT obstruction. Another double beating pulse is a dicrotic pulse. Is an unusual finding. It occurs when the diastolic pulse is conspicuously accentuated, so it becomes palpable. And these two peaks are separated by the S2. So during clinical examination, you should first find out what is S2, and whenever you simultaneously auscultate and palpate, you will learn that the two peaks are separated by S2, and the detectable delay between two palpable pulses is much longer than in bisvariance pulse. The systolic component of the dicrotic pulse is usually slow rising, small in volume, and it correlates with this residual stroke volume, as in cases of the severe LV dysfunction, extreme cardiomyopathy, or febrile condition with the septic shock. And this mostly occurs in the patients with the young patients with a very poor LV functions. It's typically associated with the low cardiac output, low blood pressure, high systemic vascular resistance, and tachycardia. Next is a pulsus alternans. So it's a pulsus alternans is present during the sinus rhythm. So rhythm should be sinus. When the patient's peak systolic arterial blood pressure and pulse volume are alternately strong and weak, like this. Once pulse is around 150 systolic blood pressure, then there is a fall of the systolic blood pressure. Again there is a rise of systolic blood pressure. So you see the alternating strong and weak pulses. So this is known as a pulsus alternans. Why does this occur? This phenomenon is related to beat-to-beat alteration in the development of LV pressure, which are caused by changing ejection hemodynamics or the changing ejection dynamics in the cardiac myocardium, and it indicates very severe myocardial depression. So this is a very typical depiction of pulsus alternans. Note that every beat has a lower systolic blood pressure, and the rate of rise of the second pulse is slower, related to decreased contractile force in the alternance beats. Pulses alternance is an important sign of very severe left ventricular dysfunction. It's a very ominous sign to detect clinically. It's the best detected in the peripheral pulses, such as a radial artery. So how to examine and why does this occur? So during examination, it's the best detected in the peripheral pulses like brachial arteries, radial arteries by application of very light pulse pressure. If you apply a very strong pressure, then you may not palpate these arteries. And carotid arteries are typically not recommended to palpate this. Use the 2-finger. There are 2 different methods. You can use also sphygmomanometer, or you can feel by the 2-finger method. In the 2-finger method, you feel the arterial pulse with the variation of, you just varies your pressure on the proximal finger to obliterate the second beat. So as you strongly increase the force of compression on your proximal finger, you feel that there is a alternately, or there is a decrease in the pulse count which is felt by distal finger. And how to accentuate or increase this sensitivity, you can ask the patient to suddenly assume upright position or take deep inspiration or ask the Valsalva maneuver, and this may be helpful in bringing out the pulses alternance. Some clinicians use the slow decompression of the blood pressure curve while simultaneously listening to alteration in the intensity of the cough sounds. Pulses alternance is not related to the electrical alternance, which may be sometimes clinically confused. What is the pulses alternance and what's the electrical alternance? So electrical alternance is a entirely different thing. It is basically related to beat variation in the height, or you can say the amplitude of the QRS complexes in electrocardiogram, which are recorded by ECG, and so typically alters in the patient with the pericardial effusion. So these are 2 pulse tracing, and you should these are most of the times shown in examine. What is on left, what is on right. This is the ECG recording upper side, and there is a lower pulse recording. So you can see on the left side there is a pulses bigeminous. So there is an alternate decrease in the stroke volume or amplitude of the pulse. So that can be confused with the pulses alternance. But you should look at for the regularity. In cases of the pulses alternates, their pulses will be regular. It will be very regular, but there is a alteration in the volume of the pulse. In cases of pulses bigeminous, pulses will be irregular with the change in the volume. So you should look for the regularity to differentiate both the type of pulses. So what is a pulses bigeminous? There is a normal beat followed by the premature beat. There is a normal beat followed by the premature beat, and whenever there is a premature beat, there is a decrease in the stroke volume. So the pulses, alternate pulses, are very weak strength. It's typically seen in the patients with digoxin or digital toxicity, and even after alternate VPC, there is a followed by compensatory pause, so which leads to the irregular rhythm. But in the pulses alternates, the compensatory pause is absent. So these are differentiating features between the pulses bigeminous and pulses alternance. The next abnormal pulse is the pulses paradoxus. So what is the pulses paradoxus? So pulses paradoxus refers to a marked and exaggerated inspiratory fall in systolic blood pressure, in which the palpable peripheral arterial pulse and audible cortical sound disappear during the inspiration. Pulses paradoxus is classically described in the patients with the large pericardial effusion with the tamponade. Because systolic arterial blood pressure normally falls slightly during inspiration, the word paradoxus is actually a misnomer, which is continued to use, dictated by widespread use of this term. Some people say that the paradox is that you continue to hear the heart sound, but the pulse is not felt. This is a paradox. And some says that the pulses paradoxus term is misnomer. So both the explanation are there in the literature for this. So what happens normally? Normally LV stroke volume decreases somewhat during inspiration because diminished left ventricular heart filling, as the inspiratory decrease in the intrathoracic pressure causes the pulling of the blood in the pulmonary bed. And this inspiratory pulling of the blood in the pulmonary bed causes a decrease in the LA and subsequently LV filling. So the systemic arterial pressure falls by few millimeters of mercury, normally less than 10 milliliters of mercury. This is a normal phenomena. And what happens during inspiration on the RV side? The RV stroke volume increases. Why? Because during inspiration, as the large inspiratory pressure gradient between the extrathoracic and intrathoracic veins causes the enhanced right ventricular filling. And this enhanced right ventricular filling causes the increased blood to the RV and subsequently increase in the RV volume. So this is a normal phenomena during inspiration. This increase in the RV filling, decrease in LV filling, causing the few millimeters of the fall of the blood pressure. As this is the same depicted in the diagram. What happens during inspiration, what happens during expiration. Inspiration, increase in the pulmonary RV and pulmonary artery blood flow, decrease in the LV and outer flow, leading to the decrease in systolic pressure. Opposite happens during the expiration. The increase in the LV flow leading to the increase in the stroke volume and increase in the systolic blood pressure, decrease filling on the RV side. So this is a normal phenomena occurring during respiratory phases. But in patients which are having the tamponade, this normal phenomenon is exaggerated. So as discussed, the inspiration normally reduces the systolic arterial pressure by less than 6 to 8 mm, or some people say by less than 10 mm of Hg. But if this inspiratory fall is exaggerated, which is more than 10 milliliter of mercury, the pulsus paradoxus is said to be present. So basically this is an exaggeration of normal physiological phenomena and not a new development of phenomena. In a severe cases with the very tamponade, the fall in the blood pressure during inspiration may be as large as 30 to 40 millimeters of mercury or even more. So how to demonstrate and how to examine this pulsus paradoxus in clinical scenario? It's very important to learn to demonstration of this pulsus paradoxus, because every alternate student or every third student is asked in examination to demonstrate this pulsus paradoxus. How do you demonstrate? What's the significance? What are the mechanisms? Then you should learn what are the mechanisms as described earlier, how to examine and what are the causes. First of all, you ask the patient to breathe quietly. You do not ask the patient to hyperventilate or perform any maneuver or ask to take deep breath. You should observe the patient, ask him to breathe quietly, and you then proceed to your examination. Assessment, how do you assess? You inflate the cuff until all cork sounds are absent, or you inflate the bulb 20 milliliters of mercury above the systolic blood pressure. Then you auscultate, keep your stethoscope on the brachial artery, and you slowly deflate the cup at the rate of 1 to 2 millimeters of mercury per second. Ask the patient to breathe quietly. Do not interfere in his respiratory or breathing. And you should first auscultate the sound which is heard during expiration. This pressure is noted. Then you continue to decrease the cuff by at the rate of 1 to 2 milliliters of mercury. And next pressure is noted when the cork cuff sounds are heard during both the phases of respiration. That's inspiration and the expiration. And you mark both the pressures, first pressure and the second pressure. And the difference between both the pressure is what quantifies the pulsus paradoxus. This is how the diagram or the graph depicts. Whenever the patient, this is the initial first portion of the pulse is during expiration, and whenever the patient takes the inspiration, there is a inspiratory fall in the systolic blood pressure, and this is depicted in this graph. And pulse volume is reduced during inspiration. What are the common causes? 3 to 4 are common causes, and the most common causes is effusion with tamponade, then the constrictive pericarditis, airway obstruction or SVC obstructions. So cardiovascular, in a depiction of pulsus paradoxus, you may have a cardiac or non-cardiac, or even a scenario whenever there is a pulsus paradoxus is even absent. The foremost and common clinical cause and the most important clinical cause is a tamponade, cardiac tamponade. Then there is effusive constrictive pericarditis. Next is restrictive cardiomyopathy, massive pulmonary embolism or severe hypovolemic shock. In pulmonary causes, you may get also in a patient of COPD. Also, you may have this pulsus paradoxus in very obese patient as described by the Abraham. There are some clinical condition in which you may have an absence of pulsus paradoxus even in presence of a cardiac tamponade. And there are 3 to 4 common causes like atrial septal defect, ventricular septal defect, and VSD, AR and pericardial adhesions. So why this pulsus paradoxus is absent in ASD, VSD or AR? There are some mechanisms. Because this respiratory variation in LV and RV filling, which is exaggerated in the cardiac tamponade, is lost in ASD patients or VSD patient, because there is a mixing of the blood in both the chambers, and the effect of the respiration on the chamber filling is nullified. So you have an absent pulsus paradoxus in ASD and VSD. In AR, during the diastole, there is the filling of the LV from the aorta, So the fall in the stroke volume does not occur, and you may absent pulses paradoxes in the patients with AR. After describing this all abnormal pulses, you should look for the condition of arterial wall, which may give very important clinical clues. In young patient, the arterial wall is non-palpable. You obliterate the pulse by proximal finger, and then you try to palpate the radial artery by the middle finger. In a young patient, you won't be able to palpate the radial artery. But in patients with older age, hypertensive patient with arteriosclerosis, you have a cord-like feeling from the middle finger. You obliterate the pulse with the proximal finger, you do not palpate any pulse, and then you look for the characteristic of the arterial wall, and you will feel like a cord-like or something hard structure. So this is typically seen in patients with the old age. You should remember this is not an atherosclerosis, but it is an arteriosclerosis, because the radial artery is immune to atherosclerosis. So the cause should be mentioned as arteriosclerosis, not as atherosclerosis. Next important portion in the pulse examination is the apex pulse deficit. Whenever examining a pulse, you should always find this finding, apex pulse deficit, and this is a difference between the heart rate and pulse rate when counted simultaneously. As during normal cycle, each heartbeat is followed by a pulse. So in a normal clinical condition, heart rate is equal to pulse rate. But whenever the heartbeat which follows a short diastolic interval is not able to generate a sufficient pressure, and you may not feel a pulse during that systole. So that part of the LV stroke volume or heart rate may not contribute to generation of the pulse wave, and you get some apex pulse deficit. The common causes are atrial fibrillation or VPCs. So how to differentiate whether the apex pulse deficit is due to the AF or VPCs? There are some common 3 to 4 differences between both these. VPC, in generally saying, in VPCs the apex pulse deficit is less than 10 per minute. In atrial fibrillation is more than 10 minutes. But this is not rule. It's a compulsory to have more than 10 or less than 10. But it's just generalized finding. Then look at the JVP. You will try to find out the A waves in JVP. In cases of the ventricular PVCs, you will have an A waves are present. But in case of atrial fibrillation, A waves will be absent. Then you will look at the rhythm. In a patient with the VPCs, there is a short pause after the VPC followed by long pause. And in case of atrial fibrillation, pauses are variable and chaotic. Then next is exertion. You ask the patient to walk for 2 to 5 minutes, and you will look for a apex pulse deficit. In cases of the VPCs, after the exertion or exercise, the PVCs decreases and the apex pulse deficits, and apex pulse deficit decreases. In cases of atrial fibrillation, it may remain constant or it may increase. And these VPCs are basically applicable for benign VPCs, which normally decreases after the exertion. Then what is a normal delay? Whenever you are palpating the pulse, you should know what time does it take for a pulse to reach a particular vessel, like a carotid pulse, brachial pulse, radial pulse, and femoral pulse. And you should remember this numerical values like 30 seconds, 60 seconds, 80 seconds, and 75 milliseconds. These are normally time which a pulse wave arises after cardiac systole. So keep one hand on the apex, other on pulse. You need to look for what is the apex pulse duration difference. So normally in carotid it arrives after 30 milliseconds, in brachial arrives after 60 milliseconds, in radial it arrives after 80 milliseconds, and in femoral it arrives after 75 milliseconds. And for the clinical finding, normally human fingers and human hands is not able to detect any difference which is less than 30 milliseconds. So to have a significant delay, the delay should be at least more than 30 milliseconds. So normally we feel that the carotid pulse is simultaneous with the apex pulse, as the difference is only 30 milliseconds. This difference is very important to clinically depict the delays: radioradial delay, radiofemoral delay, picocarotid delay. And so the common causes of radioradial delay are like pre-subclavian coarctations, thoracic inlet syndrome, cervical rib, Takayasu disease, aortic arch aneurysms. And causes for radiofemoral delay are coarctation of aorta, aortoarteritis, atherosclerosis of aorta. And one more important thing, you should look for the apicocarotid delay. Normally we feel that the apex and carotid are palpating simultaneously, but in the patients with the very critical AS or severe AS, you feel that the carotid pulse is delayed as compared to the apex. And this is a very important finding in the patient with the severe AS. Then you should look for all the peripheral pulses, like both the carotid pulse, brachial artery, dorsalis pedis, posterior tibialis. So you should, in clinical examination, you should examine all the peripheral pulses. Then arterial pulses in a specific cardiac disorder. There are some cardiac disorder we have some different type of or specific cardiac specific types of pulses, like a patient with aortic stenosis. In a patient with the severe aortic stenosis or critical aortic stenosis, the pulse is very slow rising. You can say the pulsus parvus and a delayed peak. The pulse is of very small volume and exhibits a palpable thrill at the peak of the pulse, and it displays a very prominent anacrotic notch. So typically we say the pulsus parvus et tardus. So what is meant by pulsus parvus and what is meant by tardus? So parvus is a very slow rising pulse. You see that the rise of the during systole is very slow. And the peak which comes during systole is very delayed. The peak occurs during mid systole or the late systole, and this is known as a tardus. So slow rising and late peaking pulse, typically described in aortic stenosis, is known as a pulsus parvus as tardus. You can have a palpable thrill at the peak of the systole in a patient with a severe aortic stenosis. Some people say it is a shudder, and occurs nearing or on the arterial pulse upstroke, and it represents the turbulence which is created by ejection of blood across the very narrow and distorted aortic wall orifices. So this is a typical diagram showing the pulse in a very severe aortic stenosis with a shudder during upstroke. In the upper part you have a late systolic murmur of the aortic stenosis. In the arterial pulse in aortic stenosis, there is a delayed peak. This is a very jagged contour which represents a palpable shudder or transmitted thrill, and is usually described as a pulsus parvus et tardus. Next disease where you have typical pulse difference is supravalvular aortic stenosis. In case whenever you suspect a supravalvular aortic stenosis, you should examine both the carotid pulses, because there is an unusual streaming of the blood, and this unusual congenital lesion usually frequently produces a differential streaming of the central aortic blood flow. This is known as a Coanda effect. The right carotid pulse is relatively normal. You feel that the right carotid is normal, but the left carotid pulse is a characteristic feature of an aortic wall obstruction. That's a slow rising and late peaking pulse. So this is an important of examining all the peripheral pulse. Suppose sometime you only examine a right carotid pulse and you may miss this diagnosis of supravalvular aortic stenosis. So palpating both the carotid simultaneously, you may have a clue of a supravalvular aortic stenosis. Thank you. Thank you very much.